So now we're going to start with mitral stenosis in the part 2. In the mitral stenosis, the murmur, as you can see, the characteristic findings on the auscultation will be an opening snap and mid diastolic rumble. This is opening snap, and here you can see that this is the mid diastolic rumble. Opening snap with mid diastolic rumble is heard over the apex, and the X-ray findings are straightening of the left heart border, elevated left main bronchus, pulmonary vascular congestion with cephalization of blood flow to the upper lobes. It is an important finding that there will be pulmonary vascular congestion with cephalization whenever there is accumulation of the blood in the left atrium, either because of heart failure or because of mitral stenosis or any other pathology that will lead to pulmonary vascular congestion and cephalization of blood vessel in the upper lobe. The same finding will be seen when we are going to study the heart failure. Then lateral chest X-ray can show posterior displacement and impingement of the esophagus. Why so? Because the left atrium is the most posterior structure and is immediately anterior to the esophagus. So whenever there is any dilation of the left atrium, the esophagus will be compressed, leading to dysphagia. That left atrium can also compress the recurrent laryngeal nerve, causing hoarseness of voice. So these things can happen. Complications are atrial fibrillation. Why? Because whenever there is an increase in the atrial diameter, so the impulses have a chance to complete a full circuit uh, and make a, like when impulses are traveling, they will reach the point of origin that will have come out of depolarization by then, and a circuit will be completed, and that complete circle can create uh, arrhythmic contractions or arrhythmic current flow in the atria, and that can lead to the initiation of atrial fibrillation or atrial flutter. So the enlargement of size of atria or ventricle is never good. That can predispose arrhythmias like atrial fibrillation. Mitral stenosis, the table is saying that clinical features are dyspnea, orthopnea, paroxysmal nocturnal dyspnea, and hemoptysis. Atrial fibrillation and systemic thromboembolism. There will be voice hoarseness from the recurrent laryngeal nerve compression due to the LAE. What is LAE? It is left atrial enlargement. That is called as the Ortner syndrome. So the voice hoarseness because of compression of recurrent laryngeal nerve in the cases of left atrial enlargement is called as the Ortner syndrome. Got it. Then physical examination, mitral valve, pinkish purple patches on cheeks. Okay. Mitral facies, the pinkish purple patches on the cheeks, and loud S1, loud P2. If there is pulmonary hypertension, so the P2 will also be loud. There will be an opening snap, high frequency early diastolic sound, mid diastolic rumble, best heard at the cardiac apex. Diagnosis is chest X-ray, pulmonary blood flow redistribution to the upper lobes, dilated pulmonary vessels. So the pulmonary blood flow redistribution to the upper lobe is called as cephalization. The pulmonary cephalization, right? Yeah, that is called cephalization. So the next thing is uh, dilated pulmonary vessels, left atrial enlargement, and flattened left heart border. On ECG, we will see P mitral, that is broad and notched P waves. So the P waves will have specific changes, which is called as the P mitral, that is broad and notched P waves, atrial tachyarrhythmias, right ventricular hypertrophy. Tall R waves in V1 and V2 is characteristic of right ventricular hypertrophy. Then transthoracic echocardiogram will show mitral valve thickening and calcification with decreased mobility and coexisting mitral regurgitation. Infective endocarditis in IV drug users. So infective endocarditis in IV drug users, you must remember that when they're telling you about infect IV drug users and they're talking about some valve problem or infective endocarditis, so they're specifically trying to clue you into tricuspid problems because uh, from the intravenous side, the right heart is exposed first. So that can happen. So HIV infection increases the infective endocarditis risk in the intravenous drug users. Staph aureus is the most common organism. Tricuspid valve involvement, the right side is more common than the aortic valve. Hollow systolic murmur increases with inspiration, indicating the tricuspid involvement. So the increase in inspiration is basically the indicator for tricuspid regurgitation. Okay, then we have septic pulmonary emboli. From this point, that tricuspid regurgitation, uh, I hope it is regurgitation. Yes, because hollow systolic murmur is seen in regurgitant tricuspid valve. So basically, the left and right sided murmur characteristics are pretty much same. Like if it is mitral, if you remember that mitral regurgitation causes holosystolic murmur, same is true for the tricuspid regurgitation as well. And if mitral stenosis produces mid diastolic rumble with opening snaps, the same is true for tricuspid stenosis. But for right now, with infective endocarditis, we are dealing with tricuspid regurgitation with the holosystolic murmur and everything. Septic pulmonary emboli are common. Fewer peripheral infective endocarditis manifestations, for example, splinter hemorrhages and JNV lesions, they are not seen, they're not very much common under clinical settings, but yes, when for exam purposes, the JNV lesions, the splinter hemorrhages, oscillatory nodes, these things are very important for infective endocarditis. Heart failure is more common in aortic valve involvement, but rare with tricuspid valve disease. So septic emboli due to tricuspid endocarditis. This is a septic embolus. This one is a septic embolus in what? In pulmonary artery. Yes, I guess this is ischemic area, and this too. I think so. Moving forward, we have perivalvular abscess. It is seen in the patient with the endocarditis along with the findings of conduction abnormalities on the ECG. It is due to extension of abscess in the adjacent conduction pathway. Due to the location of proximal ventricular conduction system, conduction abnormalities are most often seen in the aortic valve involvement because of periannular extension of the infection. Due to the location of proximal ventricular conduction system, conduction abnormalities are most often seen with the aortic valve involvement because of periannular extension of the infection. Are most often seen with aortic valve involvement. I just didn't get the point. Yes, aortic valve involvement and periannular extension of the infection. So what has that to do with the conduction abnormalities? Due to the location of so there is a proximal ventricular conduction system that is located close. Yes, the aorta is originating in the left ventricle, and near its opening there is a proximal ventricular conduction system. Like if I draw the heart over here, this thing, and here we have interventricular septum growing like that. There, okay, let's remove this one. This thing, this is the endocardial cushions or something, which is separating the atria from the ventricles. So let it be the mitral valve, and this is the tricuspid valve, and this is the interventricular septum, and intraatrial septum as well. So this is the location of aorta, and you know that this is the AV node, and here we have the bundle of His and Purkinje system. So if there is any problem with the aortic valve, and there is periannular extension as well, like to the surrounding tissue, so that can involve the conduction system. So due to the location of proximal ventricular conduction system, conduction abnormalities are most often seen with the aortic valve involvement because of the periannular extension of infection. Presentation: syncope due to conduction block and aortic regurgitation. Then we have the next thing, that is atrial septal defect. In atrial septal defect, we have talked about that before in the last session, that there will be wide fixed splitting of the S2. Why will that happen? Suppose this is a heart. So in the heart, this is the ASD. So this means that there will be left right shunt. From the left atrium, the more and more increased amount of blood will be flowing to the right atrium, which is not normal. Then this increased amount will go to the left right ventricle and into the pulmonary artery. When this increased amount of blood is faced by the pulmonary artery, there is hyperplasia of the muscle at the ostium of the pulmonary artery, like over here, that causes pulmonic stenosis. And this is this pulmonary stenosis which creates the murmur, which is holosystolic murmur. So yes, and also along with the holosystolic murmur, we have a split in the S2 sound, which is wide and fixed split. So features of wide and fixed splitting of S2. Ejection systolic murmur can be heard over the left second intercostal space due to increased blood flow across the pulmonic valve. Some patients with large ASD and significant left to right shunts have a mid diastolic rumble due to increased flow through the tricuspid valve. Okay. An ejection systolic murmur can be heard because of the flow through the pulmonic valve. A mid diastolic rumble can be seen in the patients who have who have a large ASD, and that is happening because of the blood flow through the tricuspid valve. Now this is splitting of S2. This is physiologic splitting, like during inspiration the A2 and P2 sound are separated from each other. P2 sound because when we are inspiring, more blood is entering the right side of the heart and thus flowing through the pulmonic artery. So the pulmonic valve closes a bit later. And during inspiration, the same process, during inspiration, decreased amount of blood is flowing into the left side of the heart, so the aortic valve is closing a bit earlier, so that separates these two sounds. But during expiration, the reverse happens and both these valves move toward both these sounds move towards each other, and the splitting is you know not audible, practically not audible. So these sounds are like close to each other, so this is splitting. The pathologic widened splitting is seen, the delayed P2 due to the delaying of the P2 that is seen in the pulmonic stenosis, in pulmonary hypertension, ASD, widened splitting with fixed throughout the respiratory cycle for the ASD and right bundle branch block. And this same splitting happens because of early A2 in the cases of ventricular septal defect. Okay, because in the ventricular septal defect, the blood that was supposed to enter the aorta, a fraction of that is going to the left, from the left ventricle to the right ventricle, and thus the aortic valve is closing sooner. So that is creating a widened splitting. Then pathological process of narrowed splitting is happening in when the A2 is delayed. That can be seen in aortic stenosis, systemic hypertension, left bundle branch block, and hypertrophic cardiomyopathy. And paradoxical split, like the A2, now the narrowed splitting was happening because A2 was moving closer to the P2 because A2 was delayed. Now, if A2 is delayed so much that it comes after the P2, that is paradoxical splitting, extreme cases of narrowed splitting. And in paradoxical split, there is another paradoxical thing that normally the split is heard during inspiration, but this paradoxical split is heard during expiration. Because right now, suppose this is P2 and this is A2, right? During inspiration, we know that norm. Okay, let me draw them again. So here we have two sounds. This is P2 and this is A2, right? Normally during inspiration, the P2 is delayed a bit. So during inspiration, the P2 moves towards A2 and the split is gone, right? And during expiration, it comes back and split is there. So in paradoxical splitting, the A2 sounds comes after P2, and there is another paradoxical phenomena that the split is heard during expiration, right? Moving forward, we have hypertrophic cardiomyopathy. It is going to produce a harsh crescendo decrescendo systolic murmur, which is same as the murmur is same as aortic stenosis, but the differentiating point is the maneuvers. There are certain maneuvers which increase the aortic stenosis murmur but decrease the hypertrophic cardiomyopathy murmur. Intensity changes are opposite to the aortic stenosis. For example, uh, this murmur increases with decrease in preload. For the hypertrophic cardiomyopathy, the murmur will increase if we decrease the preload, and the reverse is true for the aortic stenosis. Hypertrophic cardiomyopathy, left ventricular hypertrophy. So on ECG, that will be evident as tall R waves in the lead AVL with deep S waves in the V3. That is Cornell criteria, Comel criteria. So you can see that the R waves, they are tall. These are the tall R waves in the AVL, and S waves are deeper in V3. So where's V3? This is V3, and there is a deep. These are deep S waves which are seen in the V3. So that is a characteristic of the left ventricular hypertrophy. Repolarization changes in the anterolateral leads 1, AVL, V4, and V5. So lead 1, the T wave is inversed. AVL, this is AVL lead. I guess the same phenomena. There is inverted T wave. And in the V4, V5, and V6, the T wave is inverted, so that is repolarization changes which can be seen. So these are the findings you must remember. Left ventricular hypertrophy will create tall R waves in the lead AVL and deep S waves in the V3, along with repolarization changes in the lead 1, AVL, V4, 5, and 6. It is caused by mutations in the myosin binding protein C gene, cardiac beta myosin heavy chain gene. The features are harsh crescendo decrescendo systolic murmur at the apex, lower left sternal border. Murmur is increased by decrease in preload, for example, the Valsalva, and abrupt standing. Murmur is decreased by increase in preload, for example, isometric hand grip, squatting, and leg elevation. Syncope on exertion. Syncope is caused by outflow obstruction, most commonly arrhythmias, ischemia, ventricular baroreceptor response that inappropriately causes vasodilation. Okay, so syncope is mostly because of outflow obstruction. Like suppose this is the heart and this is a septum between them, and these are the ventricles, and this is tricuspid valve, mitral valve. So this is the hypertrophied interventricular septum. Now the anterior cusp of the mitral valve becomes adherent to this thickened interventricular septum, and the outflow tract to the aorta is obstructed. So that can lead to syncope. Then because there is obstruction, so the left atrium will be enlarged. That can lead to arrhythmias. There will be ischemia, and ischemia of the brain will lead to syncope, and ventricular baroreceptor response that inappropriately causes vasodilation. Um, why is there? Okay, so there is some sort of response given by the ventricles because there is increased pressure in the ventricles. So this ventricular baroreceptor response will create vasodilation inappropriately. Okay, this was the new phenomena for me. So search hypertrophic cardiomyopathy in search bar differentiate from the infant hypertrophic obstructive cardiomyopathy. There are extra points in that. Okay, so hypertrophic cardiomyopathy in infants of diabetic mother. So we have to search what um, hypertrophic cardiomyopathy in search bar and differentiate from the infant outcome. Just give me a second. Uh, and that will be a lot of it. So why are we even looking for that? So there will be some extra points and they will come later on when we read them. So let's stay focused. So they're saying that hypertrophic cardiomyopathy in infants. Okay, got the point. Hypertrophic cardiomyopathy in the infants of diabetic mother pathogenesis. Maternal hyperglycemia will lead to fetal hyperglycemia and hyperinsulinemia. Increased glycogen and fat deposition in the interventricular septum will lead to dynamic left ventricular outflow tract obstruction. The clinical findings are often children are asymptomatic, may have respiratory distress or hypotension, systolic ejection murmur. Imaging will on chest X-ray there will be cardiomegaly. Echocardiogram will show increased thickness of interventricular septum, decreased left ventricular chamber size. The treatment is with the intravenous fluids and beta blockers to increase the left ventricular volume. Then prognosis is spontaneous regression by age 1. So this is different from hypertrophic obstructive cardiomyopathy of adults, which is because of a genetic mutation. It is a fake HOCM and goes away in 1 year. So hypertrophic cardiomyopathy in the infants of diabetic mother is fake HOCM and that is going to go away in 1 year. The next thing is hypertrophic cardiomyopathy in the pathophysiology. Mutations in sarcomere protein gene, most common. It is autosomal dominant and variable expressivity and penetrance. The clinical features are asymptomatic or identified by the family screening. Fatigue, chest pain, palpitation, syncope. There will be systolic ejection murmur, which will be exaggerated by dehydration and impaired left ventricular filling. Now, the phenomena here is that suppose this is the heart, and here we have the four ventricles. So, and this outflow tract, which is, this is the aorta, which is originating here, and this is the interventricular septum. Now, the outflow tract is obstructed. If somehow we dilate the left ventricle, so because of dilation of left ventricle, the outflow tract becomes patent and more blood can flow into the aorta. And this can be done by increasing the preload and filling the ventricles and increasing the left ventricular and diastolic volume so that the ventricular size increases and the left ventricular outflow tract becomes more patent. So in cases of dehydration or in any situation that decreases the preload, the murmur of hypertrophic cardiomyopathy will be exaggerated and reverses to also. Diagnostic evaluation is done with the ECG. ECG will show left ventricular hypertrophy, repolarization abnormalities. We have seen that. The transthoracic echocardiogram will show left ventricular hypertrophy, increased left ventricular outflow tract gradient, systolic anterior motion of the mitral valve. We can perform exercise testing and family screening as well. Management is avoidance of volume depletion. Beta blockers and calcium channel blockers can be given, and calcium channel blockers, the non-dihydropyridine ones, the non-dihydropyridine calcium channel blockers, which act basically on the heart itself to decrease the heart rate. The dihydropyridine calcium channel blockers like nifedipine and amlodipine, they will worsen the condition. In hypertrophic obstructive cardiomyopathy, we are supposed to give non-dihydropyridine calcium channel blockers like verapamil and diltiazem. Complications are sudden cardiac death, management surgery if persistent symptoms, so we can perform surgery as well. So the complications can include sudden cardiac death, heart failure, and stroke. And they will sometimes give you a scenario of a very young athlete in his 20s who died of heart attack on field. So most probable diagnosis in such situation is hypertrophic obstructive cardiomyopathy. Then effect of maneuvers on the hypertrophic cardiomyopathy, and same is true for the mitral valve prolapse. The effect of maneuvers on hypertrophic cardiomyopathy and mitral valve collapse is similar. Valsalva, strain phase, abrupt standing, and nitroglycerin administration. The vents, they decrease the preload and decrease the left ventricular blood volume and thus increase the murmur intensity, because smaller the ventricle, severer the obstruction. More severe will be the obstruction of the outflow tract and thus the murmur will be intensified. Sustained hand grip causes an increase in the afterload. Squatting increases afterload and preload, and the passive leg raise increases the preload. All of these situations increase the left ventricular volume and thus decreases the murmur intensity. So if you want to decrease the murmur intensity, increase both preload and afterload. And if you want to increase the murmur intensity, decrease the preload and afterload. So this is how it works. Then auscultation of cardiac murmurs. Now, the Valsalva decreases the venous return during the strain and increases during relaxation. So we were very specific when we talked about Valsalva. We said only in the strain phase the murmur is intensified, but in the relaxation phase the murmur will be relieved definitely. So the Valsalva decreases the venous return during the strain phase and increases during the relaxation. So murmurs that get louder during the Valsalva, during the strain phase of Valsalva to be specific, are the hypertrophic cardiomyopathy and mitral valve collapse, and murmurs that get softer are all others. And this also makes sense because for all other murmurs, the problem is with the valves, not the outflow tract. So either the valve is regurgitant and producing murmurs, or it is stenotic and producing murmurs. So if we decrease the blood flow across that valve, the murmur will be, the intensity of murmur will be decreased. So that can be achieved by decreasing the preload. So all other murmurs are, the intensity is decreased for them, and for these two the intensity will be increased. When we stand abruptly, so the venous return is decreased, same thing happens. The murmurs of hypertrophic cardiomyopathy and mitral valve collapse will be exaggerated or intensified, while all other murmurs will become silenced to some extent. Then squatting increases the venous return, increases the afterload, and increase the regurgitant fraction. So the murmurs of hypertrophic cardiomyopathy and mitral valve collapse are silenced. The intensity decreases. While for the aortic regurgitation, mitral regurgitation, and VSD, their intensity increases. With hand grip, we are increasing the afterload, increasing the blood pressure, and increasing the regurgitant fraction. So the murmurs of aortic regurgitation, mitral regurgitation, and VSD will be increased. Hypertrophic cardiomyopathy will be decreased, and also the aortic stenosis will be decreased. Why will this happen? Because suppose this is the aorta and this is the stenosed aorta over here. If we are increasing the afterload, so less amount of blood will flow into the aorta. Forget about this defect, I'm just talking about aortic stenosis. So if the less amount of blood is flowing through the aorta, so through the stenosed aortic valve, the murmur will definitely decrease in intensity. So that is why with the hand grip maneuver, the aortic stenosis murmur is decreased. Now the next thing is complete atrioventricular canal defect. Now in the complete atrioventricular canal defect, the problem is that the vessels are aptly placed, but there is no differentiation. There is heart is basically a two-chambered structure. There are common atrium and a common ventricle is situated, and the vessels are placed over them. So mixed blood is moving in both vessels. Aorta is getting both deoxygenated and oxygenated bloods. So complete atrioventricular septal defect. So ASD plus VSD plus common AV valve. Fixed split S2 is ASD. Okay, so there will be a fixed splitting. Systolic ejection murmur left upper sternal border is pulmonic valve due to increased blood flow. So there are different types of auscultative findings in the complete atrioventricular defect. Firstly, we'll find a fixed splitting because of the atrial septal defect, right? Secondly, systolic ejection murmur will be present on the left upper sternal border because more amount of blood is flowing through the pulmonic valve. A hollow systolic murmur VSD, left lower sternal border. Okay, although it does not make sense to me that why will there be a VSD murmur because there is no septum per se. But okay, there will be VSD murmur as well. And hollow systolic apical murmur depending on the AV valve regurgitation. Atrioventricular valve, if it is patent, so the murmur will not be present. If it is regurgitant, so but it should be regurgitant because that is a common valve. So that hollow systolic apical murmur will also be present. So moving forward, Here you can see the ventricular hypertrophy ECG, but I think it is everything is clear in this diagram. I don't need to highlight every point. Moving forward, now ventricular hypertrophy ECG. How does it look? In the lead V1 and V2, is there an explanation? Okay, so this is what happens in the. It is normal. It is okay. Normally, lead V1 and V2 look something like this. Okay, so the in lead V1 and V2 there is prominent S wave, and in lead V5 and V6 the S wave has become shortened. This is the S wave now, and the R wave is more prominent, and we lead V5 and V6, right? In left ventricular hypertrophy, the lead V1 and V2 look something like this. There is, deepening of the R wave in the lead V1 and V2, and in the lead V5 and V6 this thing happens. It is typically convex ST segment with or without septal Q waves. Less typical is the straight ST segment with or without septal Q waves. Okay, in the right ventricular hypertrophy, normal is this, right? With the R wave and upward moving P waves. But in right ventricular hypertrophy, we have either an R S complex, like the R wave is upward pointed and R wave is more pronounced, and then we have an S wave and then inverted T wave, or maybe there is a QR complex, like there is no S wave and the Q wave is followed by a tall R wave. Both of these changes can happen with the right ventricular hypertrophy. There can also be an RSR pattern, which is an M pattern. You can see this is an M-shaped pattern. So this can also form similar to the right bundle branch clock, and or there can be an R complex. Neither Q wave, neither S wave is present, just an R complex is there. And in the V5 and V6, the S wave is still very prominent and the T wave has diminished. Okay, so this will be the structure. Abdominal aortic aneurysm, the risk factors are age more than 60, cigarette smoking, family history of abdominal aortic aneurysm, white race, and atherosclerosis. Patients are typically asymptomatic until the aorta rapidly expands or rupture. Presentation of rapidly expanding aorta is dull abdominal or back pain and distal embolization. Presentation of ruptured aorta, delayed hemodynamic instability if the bleeding is in the retroperitoneum, because the retroperitoneal bleeding is to some extent it is contained. So although the aorta is bleeding, but the hemodynamic instability will be delayed. Rapid onset hemodynamic instability and shock if the bleeding is in the peritoneum. Physical examination may reveal a pulsatile abdominal mass. It is when okay, so it is like pulsatile abdominal mass at the umbilicus as well as flank or umbilical hematomas and tenderness. Left costovertebral angle tenderness may also be present. Peripheral pulses will be decreased in a bleeding or ruptured abdominal aortic aneurysm. Risk of rupture increases in the following. So, firstly, you must remember these risk factors, like a white, old smoker Caucasian with a family history of abdominal aortic aneurysm uh, is a very high risk group for development of abdominal aortic aneurysm. So, which are the people who are prone for the rupture of this thing? If the abdominal aneurysm are large enough, like more than 5.5 centimeter, it is 5 centimeter in females and 5.5 centimeters in males. Aortic expansion rate more than 0.5 centimeter in 6 months or 1 centimeter in 1 year. Normally, the aortic aneurysm expands at 0.2 to 0.3 centimeters per year, right? I think yes, I think it is like that. So it expands at 0.2 to 0.3 centimeter per year. If the expansion is more than 0.5 in 6 months or more than 1 centimeter in 1 year, then it has a risk of expansion. And when we are doing surveillance and we are seeing that it is expanding in size, so we have to do some prompt measures in these people. Then current or ongoing smoking. Now smoking is an independent risk factor for development of aortic aneurysm and also increases the chances of rupture. It increases risk probability of degeneration of connective tissue in the aortic wall. Then female gender, usually only seen in males. If in females, the aneurysm is less common in females. But if it is present in females, then there is a high chance of rupture. Hypertension, it has a weak association with abdominal aortic aneurysm in contrast to thoracic aortic aneurysm, where hypertension has the greatest overall risk of dissection. For unclear reason, the risk of abdominal aortic aneurysm progression and development in the patient with diabetes is lower than those without the diabetes. So the reasons are not clear, but diabetes are at a favorable position. Diabetics are at favorable position in this point, that in if there is aneurysm in diabetics, so that has a slower progression in comparison to people who are not diabetic. The complications are aortocabal fistula, which means it leads to venous congestion and high output cardiac failures, which means that suppose this is the abdominal aorta and it is lying in close proximity to the inferior vena cava. So this bulging abdominal aortic aneurysm can make a fistula or make a connection with the vein. So more and more blood will be passing from the aorta directly to the veins, inferior vena cava and back to the heart. So this AV fistula decreases the afterload, and this tremendous decrease in the afterload will increase this. There will be a decrease in afterload and there will be a tremendous increase in the preload. Both of these situations will lead to a situation where we can have a high output cardiac failure. Can also lead to venous congestion of the bladder, leading to hematuria that is misdiagnosed as nephrolithiasis. So venous congestion of bladder can also happen if there is aortocaval fistula. So the bladder can have there can be venous congestion that can bleed into the bladder, and then that can lead to hematuria. Findings will include pulsatile abdominal mass and prevertebral aortic and calcifications. There will be prevertebral aortic calcification. Okay. The diagnosis is in hemodynamically stable patients. We can perform CT scan. In hemodynamically unstable patient, if we have a known history of aneurysm, go for surgery. If no prior history of aneurysm, focused abdominal ultrasound with a fast scan can be done. So yes, so evaluation of suspected unstable abdominal aortic aneurysm. So unstable, so the person is unstable and that has come to you in the ER. Symptoms suggesting of unstable abdominal aortic aneurysm include abdominal flank or groin pain, pulsatile mass, flank ecchymosis, and limb ischemia. Check for hemodynamic instability. Uh, if the person is stable, I'm sorry, okay, so check for hemodynamic instability. If there is no instability or if the person is stable, obtain the CT of the abdomen. Abdominal aortic aneurysm is identified. If yes, do the medical optimization and repair. If no, explore other diagnosis. Now, if the person is hemodynamically unstable patient with a non-abdominal aortic aneurysm, perform the emergency repair. If there is no previous history, obtain focused abdominal ultrasound. If you can see free fluid or you can find an abdominal aortic aneurysm, perform emergency repair. If no, so then look for other causes of hemodynamic instability. Treatment is surgical repair. Indication of operation or endovascular repair is aneurysm size more than 5.5 centimeter. Rapid rate of aneurysm expansion that is more than 0.5 centimeter in 6 months or more than 1 centimeter in 1 year. Presence of symptoms abdominal, back or flank pain, limb ischemia regardless of aneurysm size. Abdominal aortic aneurysm. The risk factors are advanced age more than 60, smoking, male sex, hypertension, history of atherosclerosis or CTD. CTD means connective tissue disease. The clinical presentation, mostly they are asymptomatic, but if there is rapid expansion, that will lead to dull abdominal or back pain, distal embolization, rupture. If rupture happens, that can lead to sudden severe abdominal or back pain with or without shock, and umbilical and flank hematoma. Management is with smoking cessation, elective repair for the size more than 5.5 centimeter if the person is asymptomatic. So the people can go for elective repair, urgent repair for symptomatic and hemodynamically stable patients, emergency repair of symptoms and hemodynamically unstable patients. Okay. So then we have the next point, abdominal aortic aneurysm screening. Which age group or which population group is which population group qualifies for the screening protocols. So screen the males of age 65 to 75 for abdominal aortic aneurysm if they have any prior history of smoking, that is any lifetime exposure of more than 100 cigarettes. So you have to screen these people in the 65 to 75 age group. Best method for screening is one-time abdominal duplex ultrasound. Duplex ultrasound plus Doppler colorful blood vessels. Screening may also be done in patients with age 65 to 75 with no smoking history if they have other significant risk factors. For example, first degree family history of abdominal aortic aneurysm rupture. Screening abdominal aortic aneurysm, the patient population is men, age 65 to 75. Risk factor indication, smoking history, and test is one-time abdominal duplex ultrasound. So a duplex ultrasound test is performed to diagnose medical conditions after affecting the blood flow. So this is femoral artery, then we have subsartorial vein, and this is a deep femoral vein. So the veins and arteries look something like this on the Doppler ultrasound, and this is common femoral vein. Now let's talk about thoracic aortic aneurysm. For thoracic aortic aneurysm, hypertension is a single risk factor for the rupture. Now the location, most thoracic abdominal aneurysm, like 60%, involve the ascending aorta between the aortic valve over here and the brachiocephalic artery. So like this portion, okay, I have to change the color. They're talking about this portion, like between the aortic valve and the brachiocephalic artery. So this is the region that is most commonly involved in the abdominal aortic aneurysm. A minority of aneurysm involve the descending aorta distal to the left subclavian, like distal to this point, subclavian artery. Etiology, that is just a diagram of the aorta. Let's see that. So they have shown ascending aorta. So this is left coronary artery, right coronary artery. This is ascending aorta. Then we have the brachiocephalic artery, right subclavian artery, common carotid artery. This is right common carotid artery, left common carotid artery, left subclavian artery, and descending aorta. Coming back, so over here, so we were talking about thoracic aortic aneurysm. The location, we are done with that. Etiology, age-related degenerative changes are more common. Leads to disruption of aortic wall medial layer with loss of elasticity. That leads to aortic dilation. When the elasticity is lost, so that will lead to aortic dilation. Connective tissue disease like Marfan or Ehlers-Danlos syndrome and arthritis of the vasa vasorum due to the tertiary syphilis can also be a cause. Presentation, mostly asymptomatic until discovery is made incidentally. Some patients may develop chest or abdominal discomfort as thoracic abdominal aneurysm grows to compress the surrounding structures. If they are compressing, the esophagus, so there will be dysphagia. If they are compressing the trachea, so that will cause, hoarseness or dyspnea, something. Yeah. So diagnosis is made with chest X-ray. On chest X-ray, we will see a widened mediastinum, enlarged aortic knob, and tracheal deviation. CT scan with contrast is diagnostic. So this is not a ruptured thoracic aortic aneurysm. Just because of its mere presence, it can cause widening of mediastinum. The aortic knob is enlarged. Okay, and we have tracheal deviation as well. And this is widened aorta. Okay, the differentials of the thoracic abdominal aneurysm are hilar mediastinal lymphadenopathy. Enlarged lymph nodes appear as opacities that are discrete from the heart borders. So these are left hilar lymphadenopathy and this is right hilar lymphadenopathy. It has nothing to do with the heart borders, but so they're like this is the heart border, and here we can see lymphadenopathy, and same is true here. Mediastinal widening due to the lymphadenopathy is present. Okay. Now here you can see that coronary angiogram. In coronary angiogram, how do we perform a coronary angiogram? How do we perform a coronary angiogram? Okay, so a catheter engaged into the heart artery. So I think it starts from here. It starts from below upwards. So this is the first point, a puncture site in the groin area or maybe wrist. The catheter is passed towards the heart and then it is engaged into the heart artery we are interested in. This is Doppler versus duplex ultrasound. So this is a chart about it. So let's see the chart. So they are saying, by definition, Doppler is a medical non-invasive study of the heart and blood vessels using the ultrasound with high frequency waves. A duplex is a medical non-invasive study combining the traditional ultrasonography and Doppler ultrasonography. Output, a color picture detecting the blood flow. Let's read them one by one. So for the Doppler, it is a medical invasive study of the heart and blood vessel using the ultrasound with high frequency waves. A color picture detecting the blood flow will be seen, and information presence of blood flow in the studied vessels, its detection, speed, turbulence, etc. is seen. For the duplex ultrasound, the definition is that a medical non-invasive study combining traditional ultrasonography and Doppler ultrasonography. The output is that a color picture detecting the blood flow and two-dimensional grayscale ultrasound image of the tissue. Information is presence of blood flow in the studied vessels, its direction, speed, turbulence, etc. Image of the surrounding tissue will be seen. So I guess this does not show the image of the surrounding tissue, the Doppler one, and duplex shows it. So this is the CT contrast and CT without contrast. So this is the CT without contrast and this is CT with contrast. So you can see that in the CT with contrast, the kidneys are very prominent. Yes, the pancreas is very prominent. The stomach is was previously prominent as well. The liver is more prominent. So this is like, you should perform CT with contrast when it is indicated. Now moving forward, the ACLS guidelines for the adult tachycardia with pulse. So the ACLS guidelines, adult tachycardia algorithm with pulse, advanced cardiac life support guidelines. Assess the appropriateness for clinical condition like heart rate typically more than 150 per minute if tachyarrhythmia. Identify and treat the underlying cause. Maintain patent airway, assist breathing if needed, oxygen, cardiac monitor to identify the rhythm and monitor the blood pressure and oximetry. Persistent tachyarrhythmia causing hypotension, altered mental status, signs of shock, ischemic chest discomfort, acute heart failure, which means that the patient is unstable. If yes, do the synchronized cardioversion, sedation. If regular narrow complex, consider adenosine. If the rhythm is, if the QRS complex is regular and narrow, so consider adenosine, and you can also sedate the patient. If the patient is not unstable, QRS duration, look for QRS duration if it is more than 0.12 seconds. If yes, so IV excess and felt lead ECG, consider adenosine if regular and monomorphic. Consider anti-arrhythmic infusion like amiodarone for the ventricular tachycardia and consider expert consultation. Adenosine acts on the receptor in the cardiac AV node, significantly reducing the conduction time. So if the QRS complex is not more than 0.12 seconds, then we can give IV access and 12-lead ECG, vagal maneuvers, adenosine if the rhythm is regular, beta blockers and calcium channel blockers, and consider expert consultation. Cardioversion. Cardioversion is a medical procedure that restores a normal heart rhythm in people with certain types of abdominal heartbeats like arrhythmias. Cardioversion is usually done by sending electrical shocks to your heart through the electrodes placed on the chest. It is also possible to do the cardioversion with medications. Now here you can see use of vagal maneuvers and adenosine. Use of vagal maneuvers and adenosine can do this. Like if you are doing the carotid sinus massage, like this was tachycardia, after doing carotid sinus massage, the heart rate decreased like to this extent and like this. And the moment you stop, like this is the period when the uh, tachycardia has been relieved, but the moment you stop the carotid massage, tachycardia comes back. But after you administer the adenosine, the tachyarrhythmia is abruptly terminated and normal rhythm is attained. Okay. After that, we have here the irregular heart rhythm before cardioversion, and then we have a normal cardiac rhythm with cardioversion. The cardioversion pads are placed on the chest and back. This is cardioversion machine and tachyarrhythmia framework. So this is, I guess, a management plan. So if we are having a narrow QRS with a regular rhythm, it is sinus tachycardia. It can be sinus tachycardia, AVNRT, orthodromic AVRT. Okay. Then we have atrial tachycardia, atrial flutter, or junctional tachycardia. The irregular rhythm with a narrow QRS complex and tachyarrhythmia can be caused due to atrial fibrillation, atrial flutter with variable AV block, and multifocal atrial tachycardia. Wide QRS and regular rhythm, it can be caused by ventricular tachycardia, supraventricular tachycardia with bundle branch block, antidromic AVRT, and pre-exciting SVT. So, like suppose this is the heart, these are the ventricles, these are atria and ventricles. If the re-entrant impulse is moving from the ventricles to the atria, it is called as orthodromic. If it is moving from the atria to the ventricles, it is called as antidromic. Yes. I think it is so. Yes, it is like that. Actually, orthodromic means the normal pathway, right? So the normal pathway is like the impulses move from the AV node to the ventricles and then they come back, right? So this is orthodromic. But if the reverse is happening, like the impulses are moving from the ventricles and no, I'm sorry, but if the impulses are moving instead of coming back from the ventricles to the atria, if they start going from the atria to the ventricles, so this is antidromic. So this is the concept. Moving forward, now here you can see that there are certain EKG changes which are highlighted in this graph. Okay, so let's read them. So EKG, I think I should zoom it out. I hope it is visible. So they're saying that in EKG, if the arrhythmia, if we have bradycardia, that is the heart rate is low, less than 60, then we look at QRS. That either the QRS is less than 0.12 millisecond or more than zero point 0.1, less than 0.12 second or more than 0.12 seconds, right? Normally the QRS is 0.12 seconds 0.12, right? Matlab, I mean, it is like 0.12, I guess it is milliseconds. Okay, just don't get confused on the units. It is milliseconds. So if the QRS is more than 0.12 milliseconds, then so we look for that. So if it is narrow, so it can be sinus bradycardia, first degree AV block, that is prolonged PR interval and no drop beats, normal PR interval 0.12 to 0.2. Okay, so then second degree block type 1, progressively prolonging PR interval until the beat is dropped. Second degree block type 2, prolonged PR interval with random dropped beats. The third degree block is AV block P waves buried inside the wide QRS, and the widest QRS is seen with the IV rhythm, interventricular rhythm, that is wide complex QRS and no P waves. So pace if unstable, so moving in this direction, starting from sinus bradycardia to IV rhythm, you should start pacing if the person is unstable, and we can also use adenosine. Okay, now here is a picture. For that I have to zoom it in. This is a picture about the heart blocks. So this is second degree AV block, Mobitz type 1. In Mobitz type 1, the thing is that the PR starts prolonging at a regular interval until a beat is dropped. So this is the PR interval PQ. So the PR, as you can see, that this PR is smaller, then it became larger here, then it became longer, still longer here, and a drop beat is dropped, and again the PR starts progressively enlarging and the beat is dropped. This is type 1, uh, Morbid type 1 or Venki back heart block. Second degree AV block type 2. So the PR is fixed, but after certain intervals, we have a dropped beat. As you can see, that after these two beats, we have a dropped beat, then these two beats, we have dropped beats. So there is a certain condition they can ask you in MCQ, that what is the condition in which we cannot differentiate between Mobitz type 1 and Mobitz type 2. So that is if the ratio between the P waves and drop beat is 2 to 1. Like if there is, for every 2 beats, if there is one dropped beat, so we cannot see if the PR interval was prolonged or not. So in if the 2 to 1 ratio is present, like this is a 2 to 1 ratio, but there is a 3 to 1 ratio. So this can be a type 1 block or type 2 block, because we cannot comment on the PR prolongation. Then we have third degree block. So in third degree block, it is a complete AV block. So you can see that the P waves are present independent of the QRS. So, and the distance between the P and P waves is same, and the RR interval is also same, but they are contracting independent of each other. And this is idioventricular rhythm. So IV rhythm, I guess this one was that, and I don't know what does that mean. So this is idioventricular rhythm. I guess this is when the impulses are generated and produced totally inside the ventricles. Then we have this side of the flow sheet diagram. So they are saying about tachycardia, like if the heartbeat is more than 100 beats per minute. Okay, there's so tiny diagrams. I have to zoom so much. Okay, so this is a very, I don't know what this is dorsal diappointus. That is what I know, and this is something which is not visible, I guess. Okay, I don't know. I can't comment on that because I can't even see that. So, okay, I think we can see that. Just give me a second. No, actually, I just tried to see that in a different PDF editor, but it is not visible. So, okay, so just give me a second. Yep. We were talking about tachyarrhythmias, like if the heart rate is more than 100 beats per minute. Now again we look at the QRS, if it is narrow or wide. If it is less than 0.12 millisecond, it is narrow. If it is more than 1.12 millisecond, it is wide. So the narrow situations are in supraventricular tachycardia and atrial fibrillation, and the QRS is wide in the torsades and VTach, so it will be ventricular tachycardia. Yeah, you can, if you can squint your eyes a bit, so you can see this is the rhythm for ventricular tachycardia. So for the supraventricular tachycardia, if the person is stable, give adenosine 6, 12, 12. Okay, this may be the dose. And if the person is unstable, then you have to cardiovert the patient. If the no P waves are more than 150 and regular rhythm is present. For the atrial fibrillation, firstly you can go for the rate control and rhythm control. For the unstable patient, cardiovert the patient. If there are no P waves or irregular and less than 150 beats per minute, the chaotic background. In chaotic background, if the person is stable, rate control with the calcium channel blockers like diltiazem, then determine if there is new atrial fibrillation less than 48 hours, do the cardioversion. Old or unknown, transthoracic echocardiogram eval first. Transthoracic echocardiogram 2D echo, valvular or non-valvular. So there is CHADS. Now what is that? Okay, so for the torsades, if it is there, so give magnesium, or you can give the shock with a changing amplitude. For the VTech, give amiodarone shock, or what? I guess give magnesium, or if the person is in shock, then you can give a changing amplitude or something. Okay, I don't know what does that even mean. And for the ventricular tachycardia, give amiodarone shock monomorphic. But just forget about this thing. I don't know what is the meaning of shock. Atrial fibrillation prevent the stroke. In atrial fibrillation, we have to prevent the stroke. Determine the cardioversion benefit. If there is a benefit for cardioversion, that is present if the person is younger with no coronary artery disease, no structural disease, low comorbidities. But if the situations in which there is no benefit of cardioversion, these are rate control. So if there is no benefit, so do the rate control with anticoagulation per CHADS score. So the CHADS score is congestive heart failure has one score, hypertension one score, age more than 75 one score, diabetes mellitus one score, stroke has one score, and again stroke has one score. So anticoagulation into 3 weeks. So to prevent the atrial fibrillation, we have to prevent the anticoagulation. We have to give anticoagulant for 3 weeks, then transesophageal echocardiogram, then cardiovert, then anticoagulation for 4 weeks. And the CHAD score, if it is 0, give aspirin only. If it is 1, consider 2 plus anticoagulants, that is low molecular weight heparin bridge and warfarin 2 to 3 INR. Okay, this was so confusing. I'm just tired. This is if the person is unstable, cardiovert the patient. If the person is stable, give adenosine, diltiazem, magnesium, amiodarone, and then defibrillate. Okay, this is not from Uworld. This is from Google, and very long and pesky kind of worksheet. Okay, so before moving to the sinus bradycardia, I would like to end the session here, and then we'll continue from the sinus bradycardia in the next session. Until then, Allah Hafiz, fi amanillah, and take care.